the fifth wave of the case box. I think we're still waiting for Julia to join us. But before we start the activities of the case box fifth wave, which is a joint meeting with the JAG case reports, we have here a bunch of experts, eminent experts, and I think we will enjoy tonight a fantastic sessions. We have the first session, which is the current status of dyslipidemia, will be moderated by Professor Atif Al-Bahri. And then we will have a first session in the case box, which will be moderated by Professor Ayman Abu Al-Majd. And I think we have a bunch of interesting, exclusive, if I can mention, cases. Then we have a third session, which will be moderated by Professor Hani Raja. And I think to keep up the time, we will now give the mic to Professor Atif Al-Bahri. Hello, Professor Tariq. Welcome. Professor Karim, Professor Heba, welcome. And I will leave the mic now to Professor Atif Al-Bahri.
Thank you very much, Professor Said Farag, for the introduction, and I welcome everyone. And I'd like to thank you for your big effort in this case of IAVA Cardigo. I am honored also to moderate the first session presented by Professor Ashraf Rida, President of IAVA. Dr. Ashraf Rida will shed light on the current status of familial hypercholesterolemia in Egypt, which is a very important matter that is concerning our country. Please, Professor Ashraf.
Well, thank you, Professor Atif, and I would like to welcome you all in this fifth wave of IAVA Casebox wave, which is in collaboration with the ACC case report. I would like to thank Said Farag and Julia for their sincere and continuous interest in preparing for these very interesting sessions. I would like to thank Sanofi for sponsoring the first session symposium. I will present some data about familial hypercholesterolemia, both globally and some data from Egypt. Actually, when we talk about familial hypercholesterolemia or genetic cardiovascular disease in general, we know that to have genetic disease affecting the cardiovascular disease, it either be monogenic disorder affecting one gene, as you know, in case of heterozygous or homozygous familial hypercholesterolemia, which can affect LDL receptor gene, ApoB receptor gene, or PCSK9 protein. The other way that genetics can affect cardiovascular disease is when we have complex disorders or polygenic disorders affecting many genes. We are born with different risk alleles in our bodies related to, for example, blood glucose, metabolic syndromes, hypertension, vascular endotheliums. And the more risk allele you have, the more chance that you have premature atherosclerosis. Of course, we are concerned today on the rare presentations of monogenic disorders like familial hypercholesterolemia. Actually, if you ask which gene is responsible for these disorders, it is mainly the LDL receptor gene. In 80% of the cases, the defect is in the LDL receptor gene. However, sometimes it may be in the ApoB, in the PCSK9, or even maybe polygenics. And you don't need to do genetic testing to diagnose these disorders. Of course, the genetic testing is confirming the diagnosis. However, by using something like Deutsch criteria or other criteria that put in consideration the family history, the history of the patients, the presence of premature atherosclerosis, the lipid profile, and some physical findings like the nsoma and the plasma and arcus senilis. Of course, this could be using this criteria, we can detect a lot of cases of familial hypercholesterolemia, possible, probable, or definite familial hypercholesterolemia cases. If you look at this nice registry of Korean populations to see the LDL cholesterol distribution in about 35,000 individual. We will notice that most of the patients or the general populations, LDL is around 100, from 70 to 130. These are here the most LDL cholesterol lie in this area. However, rarely you have some populations with LDL cholesterol above 200s, and as you see, the percentage of patients is here, and many of these patients are probable or even definite familial hypercholesterolemia. Yes, familial hypercholesterolemia. The Egyptian Cardio Risk Project, and this was the first project to give us an idea about the possibility of having a real problem of familial hypercholesterolemia. These projects actually include 31 centers all over Egypt, ICU centers. We included more than 3,000 patients from 2015 to 2018. All these patients are patients with acute coronary syndrome. And the main questions of this observational study was to see what are the most important risk factors among Egyptian patients with acute coronary syndrome. What is the age of onset of patients with acute coronary syndrome? And actually, one of the striking results of these projects, which was published in European Heart Journal and in atherosclerosis, is the prevalence of patients with premature atherosclerosis. If you look at this on your left-hand side, the males, and on your right-hand side, the females patient, Egyptian patient with acute coronary syndrome. In male, for example, this blue and orange and gray color, all of them are patients below the age of 56 years old. So below 55 years old is the blue and orange colors. So we have around 47% of Egyptian male and more than 60% of Egyptian females presented with acute coronary syndrome prematurely. So this highlighted the issue of premature atherosclerosis in Egypt. So many of our patients have premature atherosclerosis. And as you know, premature atherosclerosis could be explained either the presence of multiple risk factors, because we have high incidence of smoking, obesity, metabolic syndrome, hypertension, and diabetes, and also the possibility of familial hypercholesterolemia, especially at this age group, is heterozygous familial hypercholesterolemia is there and is of concern and should be highlighted to take care of. There was an important paper published in the Atherosclerosis Journal, the overview of the current status of familial hypercholesterolemia care in over 60 countries. The ES Familial Hypercholesterolemia Studies Collaborations. And in these papers, we share with some data from the Egyptian Cardio Risk projects, and it was quoted from our data that preliminary data from the Egyptian Cardio Risk project showed premature atherosclerosis in 47% of men and 69% of women admitted with acute coronary syndrome, in whom 50% of those patients with premature atherosclerosis may have really heterozygous familial hypercholesterolemia. If you look at the picture of acute coronary syndrome worldwide, on your left-hand side, this is the general population of acute coronary syndrome, and on the right-hand side, population with premature acute coronary syndrome. And this column represents the incidence of probable and possible familial hypercholesterolemia. Generally, in patients with acute coronary syndrome, maybe 20% of the patients may be possible or probable case of familial hypercholesterolemia. However, if we took patients with premature atherosclerosis, we'll notice that around 50% of them may have really familial hypercholesterolemia. So 50% of patients with acute coronary syndrome is premature, and 50% of the premature is probable or possible cases of familial hypercholesterolemia. So we can state that in general, around 20% of patients admitted with acute coronary syndrome may be actually probable or possible case of familial hypercholesterolemia. And this is very important because if we detect those patients, you can be aggressive from the start in the management. You can start even with combination therapy because it is difficult to reach the goals with only statin therapy in these patients. So we did some post hoc analysis in the patients from the CardioRisk project to see the prevalence of familial hypercholesterolemia in our patients. As you know, the projects of CardioRisk was not powered to detect patients with familial hypercholesterolemia. However, we have group of patients with premature atherosclerosis and the group of patients without premature atherosclerosis. We have the lipid profile, we have the family history, so all our patients are having ischemic heart disease. So we can say that those with LDL 155 to 250 is a possible. Those with 250 to 325 is probable, and those above 325 milligram per deciliter is definite case of familial hypercholesterolemia. That's how we calculated the possible prevalence in this case, and we subgroup the patients into those with premature acute coronary syndrome and those without. And actually, if we look at those without premature atherosclerosis, if the LDL is from 190 to 325, this is possible FH, and if it is above 325, it is probable FH patients. So in general, among our patients with acute coronary syndrome in the Egyptian CardioRisk projects, we have around 16% of cases of possible familial hypercholesterolemia and 0.25% of probable and 0.1% definite familial hypercholesterolemia. These are the results in the general population of patients with acute coronary syndrome. I'm sure that if we do the same calculation in patients with premature atherosclerosis, the numbers will be more and more. We was in IAVA incorporated in the important study of familial hypercholesterolemia collaboration studies of the European Atherosclerosis Society. And that was a great opportunity for us to include our patients with familial hypercholesterolemia. So in this study, it could be considered as an Egyptian registry of cases with familial hypercholesterolemia included in the EAS registry, including more than 60 countries around the world. And this is some data from this registry. This is the preliminary results of the Egyptian Familial Hypercholesterolemia Research Forum registry. And as we see on your left-hand side, in our patients with familial hypercholesterolemia, we are divided into 30% definite, 12% probable, and 57% possible. And if we look at the phenotypes of these patients, our patients with familial hypercholesterolemia are characterized by the presence of multiple risk factors like hypertension, 30%, obesity, 50%, smoking, 22%, consanguinity, 60%. So our patients with familial hypercholesterolemia seems to be more risky because they have additional risk factors like obesity, diabetes, hypertension, and smoking. And this is a burden for us to treat such patients because they need early detection, they need early treatment, and they need aggressive treatment from the start to trying to prevent cardiovascular atherosclerotic event. This is some data from the registry regarding the lipid profile of our sample of Egyptian patients with familial hypercholesterolemia included in the European Atherosclerosis study. That mean total cholesterol 316, LDL cholesterol 237, HDL 47. Of course, all of these are in milligram per deciliter. Triglyceride 190 and lipoprotein little a 42 milligram per deciliter. Regarding the management strategies or management in this sample of Egyptian patients with familial hypercholesterolemia, the combination non-statin therapy, most of them, or more than half of them, using ezetimibe. However, the use of combination therapy was only in 56% of these patients. Despite that, they are, as I see, high-risk patients. The other observation is the use of PCSK9 inhibitor at that time, couple of years ago, was very low, around 2.6% only of familial hypercholesterolemia patients registry are on PCSK9 inhibitor. That's why we share with European Atherosclerosis Society and the WHO and the other organization of familial hypercholesterolemia global summit in writing an important paper in JAMA Cardiology about reducing the clinical and public health burden of familial hypercholesterolemia, a global call of action. That was very important papers, and I think it was the first paper after about 25 years of the first one about call of action of FH patient from the WHO. The important message of this global call of action is the awareness. This is very important because awareness of the problem of familial hypercholesterolemia is very defective amongst general population, defective among the governmental bodies, even defective among physicians. When a physician see a 51 years old or 49 years old patients in his clinic with a history of myocardial infarction, many of them did not put in mind the possibility of heterozygous familial hypercholesterolemia. And what is the usefulness of putting this possibility? The usefulness is you can screen the family, you can screen his sons and daughters, you can screen his brothers, even his father and mother for the possibility of familial hypercholesterolemia. So awareness also, this is a sample of awareness for the general population, some recommended samples. For example, we can, what is familial hypercholesterolemia? Some simple definitions to put to the general populations. Know the signs of familial hypercholesterolemia, whether some numbers about the lipid profiles, nodules and the xanthelasma, the white ring around the cornea. Also how to treat in order to emphasize the importance of lifestyle intervention, the importance of using combination therapy, and also we have to stress the fact that familial hypercholesterolemia runs in families. So once one is diagnosed, we should look at the other members of the family, especially first degree relatives. There is one important question that need to be highlighted for physicians and for those who are concerned with FH is what is the best age of screening? Of course, the best age of screening depends on the family history of and the history of premature atherosclerosis. However, some cases of FH, especially homozygous, you can even screen the newborn. But however, all our children around the age of 10 years should have at least lipid profile once in time, and maybe repeated at age of 25 to 35 years of age. Important screening is child parents cascade screening. You know, the usual screening is when you have a patient with familial hypercholesterolemia at age of 45 years old, premature atherosclerosis, for example, you will look at his sons and daughters. However, when you detect a child with familial hypercholesterolemia, you should also do some lab and some investigation, some physical examination to his parents, and this is called the reverse screening or child parents cascade screening. This is very important. However, effective screening is not easy, and we have barriers to effective cascade testing or cascade screening, like, for example, the variation in healthcare and genetic privacy policy, the lack of knowledge and skills among the providers, the poor communications in family to see where is your aunt, where is your uncle, maybe there is no communications. The underutilization of genetic counseling services, it is difficult, it is not available, and even if it is available, it is underutilized, and of course, lack of knowledge of best risk notification methods. Let me finish with these 9 policy priorities that we wrote in the paper of global call of action regarding the FH all over the world. These 9 priorities for improving FH care include creative awareness. This is very important, the awareness, as I told you. Continued advocacy organization around the world provide patient support and education. Also, the screening, the testing, and the diagnosis should be highlighted. The accessible treatment should be easy to access, especially in health care systems, in insurance organizations, and so and so. Also, we need guidelines specific for cases of homozygous familial hypercholesterolemia. Data are very scarce, and we don't have a lot of data to support guidelines, but we need guidelines for homozygous familial hypercholesterolemia. We should organize for family-based care, not only patient-based care, because the patient with familial FH has a member of his family have the same problems, and you should take care of all the family, not only the patients. We should have registry and research in this field to try to look at the prevalence, the real prevalence, because we don't know till now the real prevalence of FH in most of the countries around the world. We have a lot of percentages, a lot of numbers, but none of them are accurate. It seems that the problem is more than we realized, and I hope we can put these 9 policy priorities trying to improve the care of FH patients. Thank you for your attention. I leave the microphone to Professor Atif, and I will stop sharing.
Thank you very much, Professor Ashraf, for your great, illustrative, valuable presentation that make us happy with that we have all this data. It seems we have in Egypt a problem. Many unscreened patients with familial hypercholesterolemia and lack of awareness among physicians and the population too. So it's our job as IAVA to spread the awareness among the physicians and people to get good data to manage and prevent premature atherosclerotic cardiovascular disease. Can you shed light on what steps we should do in Egypt here for our population to prevent and to manage FH patient? Is it the 9 policy priorities you show for the last slide, or we can do others?
Well, I think because FH in general is rare disease. However, the prevalence of premature atherosclerosis among Egyptian patients is high. And we have to convince the authorities, healthcare authorities, about the problem of premature atherosclerosis. Realize a man of 45 years old with myocardial infarctions, how is the burden of disability, how is the economic burden on him and on the family, the social and psychological burden on the family of having myocardial infarction at years of 45 or 50, even 50 years of age. So we have a problem in Egypt that most of our healthcare authorities thought that for example, the liver disease is more important than cardiac disease. And I think we have defect in supplying this data to the authorities to convince them that the cardiovascular disease is the #1 killer in Egypt till now by far, even more than cancers in Egypt. And the prevalence of premature atherosclerosis is very serious, actually, as I showed in our data, that nearly half of our patients with acute coronary syndrome in the intensive care are premature atherosclerosis. I'm sure if we ask about the family history, and if we do some simple tests like lipid profile for the first degree relatives, we can detect more and more. Let me welcome Dr. Julia. Thank you for being with us. Thank you for your support.
Thank you. Any question from the panelists?
Yes, I'd like to ask, I will take the opportunity that Julia joined us now. Do you have a submitted cases in the JACC case reports about familial hypercholesterolemia cases? Do you have? Because we are thinking about doing a wave about the familial hyper, because we have a lot of cases. We have a bunch of cases. Professor Ashraf, yes, we have. Yes. We have
we have cases of stents in
we 9 have
years,
cases.
9 years old.
I think, first of all, the prevalence of familial hypercholesterolemia may be much more we have received, I think we have almost approximately 3 to 4 cases. We don't receive cases at the weekly basis. Practically, I think Rafa has handled a lot of cases of familial hypercholesterolemia. Yes, we could do a wave on hypercholesterolemia and maybe, complications.
Yes, I think if you announce that we will do a wave about the familial hypercholesterolemia cases and its consequences, I think you will find in your archive a bunch of cases which will be interesting for the audiences.
That's fantastic. Yeah.
Professor Atif, if you don't mind, we are going to close this session for the current status of hypercholesterolemia. And I think we will now start by giving the mic to Professor Ayman Abulmagd. I think he is with us. He will be the moderator of the first session. Professor Ayman Abulmagd is a professor of cardiology at Azhar University. He is one of the eminent professors in Egypt. He is one of the eminent interventionists also in Egypt and the eminent cardiologist. I think he will give us a nice moderation, a fantastic moderation for the coming session. And I'd like again to thank the JACC case reports represented by Julia Graspa, the chief editor of the JACC case reports, that give us the opportunity to give these educative waves. And I think now we will go for break and we will start the first session.
It gives me a great deal of pleasure to introduce several exciting presentations. The first will be from Professor Karim Mahmoud from Cairo University. It's entitled The Journey of Heart Failure Patient When the Diagnosis Begets More Complexities. Professor Karim.
Thank you, my dear Professor Dr. Ayman Abulmagd. I'd like to thank IAVA CardioGo board and JACC case report for this wonderful meeting. This is a case of a patient with worsening heart failure. So this is a 60-year-old male. He had mitral valve replacement 5 years ago before presentation and possibly due to a rheumatic heart disease. He is known to be hypertensive. However, his blood pressure on presentation was 100/80 millimeter mercury, and he was compliant to all his medication. The patient, the problem started one year ago with recurrent hospital admission due to heart failure function class 4 and rapid atrial fibrillation. Dr. Ayman, can you hear me?
Yes, we can hear you.
Yes, we can hear you very well. We can hear you very well.
Okay, thank you. In between admission, the patient
We can't hear you now. Your voice is gone now.
Seems that the net is.
Yeah, he lost the internet.
Yes.
Is it something to do to fax to help him?
So till this is solved, let me, Syed, review the case. Till now, you remember the case, 6 years with heart failure and possible rheumatic heart disease. It is not usual for a patient with rheumatic heart disease to have his heart failure at this age.
Yes, it seems it is unusual, yes.
If we can comment on what little data we have.
Yeah.
I would assume it was most probably due to mitral regurgitation, because
this is a possibility. Another possibility is additional other causes rather than rheumatic heart disease, maybe hypertensive heart failure, ischemic heart disease.
Also, yes, very possible.
Sorry for the connection error. Can you hear me?
Go ahead.
Okay. So this patient with recurrent admission due to heart failure, in between he has severe still heart failure with the shortness of breath function class 3, and his ejection fraction is reported to be 35%. This was his ECG. ECG showed the left bundle branch block with atrial fibrillation of a rate of 90 to 100. And his X-ray showed a cardiomegaly with evidence of pulmonary congestion. As you have mentioned, the causes of this heart failure could be a mechanical valve dysfunction due to a paravalvular leak, thrombosis, pannus, or others, severe systolic dysfunction, coronary artery disease, arrhythmias, the patient already had atrial fibrillation, non-cardiac causes such as anemia, thyroiditis, or CKD, or others. I first saw this patient in outpatient clinic, so we started to exclude the cause that precipitate the heart failure in this patient. So this was his old echocardiography. At first, we excluded the atrial fibrillation as a cause of worsening heart failure because his rate is more or less control of 90 to 100. So we searched for other causes of heart failure. This is his echocardiography that showed dilated left ventricular dimension with ejection fraction 35%. The mitral valve was well functioning. There was aortic valve disease in the form of moderate aortic stenosis with a mean gradient of 23 millimeter mercury and severe tricuspid regurgitation, which was functional, and elevation of pulmonary artery systolic pressure of 55 millimeter mercury. So we excluded the mechanical valve dysfunction as a cause of heart failure worsening in these patients. The severe systolic dysfunction can still be a cause of the patient's symptom or could be another due to, as the patient we mentioned, he had other valvular lesions. For exclusion of coronary artery disease, the patient had coronary angiography 1 year with a BCI to a stable lesion in the second obtuse marginal branch, which was a 60 to 70% stenosis, unlikely to be the cause of his symptom. And he had another coronary angiography 9 months later with that showed patent coronary stent. So coronary artery disease was excluded also. And regarding the labs, all his labs were more or less normal. Creatinine was 1.2, CBC hemoglobin was 11, normal thyroid function, and no other lab abnormality. So the non-cardiac causes also were excluded. So we are left with severe systolic dysfunction or other causes. And this was where his medication, he was on warfarin, clopidogrel, sacubitril, valsartan 100 milligram BID, carvedilol 12.5 milligram twice, amiodarone 200 milligram, furosemide 125 milligram once, and spironolactone 25 milligram. As you can appreciate, the patient was on good medical treatment. So still severe systolic dysfunction can be a cause, but we should search for other causes. So we repeat the echo. This is a reminder of the echo that was done 1 year ago. And you can appreciate the echo at the time of presentation with severe systolic dysfunction. The ejection fraction is less than 20%. We have, this is the shadow of echogenic shadow of the mitral prosthesis. And we can appreciate also the aortic valve disease with reduced excursion and thickened aortic leaflet. Also, the patient has a moderate degree of aortic regurgitation, as you can appreciate in this echocardiography. And this is the short axis view showing the reduced excursion and the thickened trileaflet aortic valve. The apical fluid chamber view, you can appreciate also the severe systolic dysfunction that the patient had. The gradient across the mitral valve was okay. And the gradient across the aortic valve, the big gradient was 2.5. It's not significantly high on this resting study. So despite we concerned about the cause of worsening also left ventricular dysfunction over 1 year from 35% to less than 20%. So we decided to do more assessment for aortic valve using the dobutamine echocardiography. And surprisingly, the dobutamine echocardiography showed significant increase in the gradient across the aortic valve. And this was with fixed aortic valve area. So the peak systolic velocity increased from 2.4 meter per second to 4.1 meter per second. And the mean gradient increased from 15 to 38 with improvement in ejection fraction. This was the fixed aortic valve area. So we did a heart team for this patient, and actually he has a high surgical mortality. So we started to thought about the TAVR as a possible treatment for this patient. And we do more assessment of the aortic valve using the CT. As you can appreciate, there is no increased calcification. There is a spot of calcification of the aortic valve, and the possibility of that aortic valve to be aromatic or chromatic etiology can be. We started to assess the diameter of the aortic valve. The average diameter was 26.6 and the perimeter was 85.8, suggesting the possibility of implanting a large device. This was the dimension of the sinus of valsalva and the sinotubular junction, tubular aorta. And also we assess the distance between the aortic annulus and the prosthesis, because we don't want to our device to hinder the function of the mitral prosthesis. The height of the left main was acceptable, more than 11 millimeter, and his vascular axes were fine. As you can appreciate, there is no much calcification of his abdominal aortoiliac axis. And we choose the left axis, left iliac, because it's more straight and with absence of any calcification. The coronary angiography also were fine. There is no significant disease of all his coronaries with patent stent in the obtuse marginal branch. So we started, we prepared this patient for a TAVR. The patient is not very good to withstand this procedure, and he was still in heart failure. So we did the procedure under general anesthesia. As we started the anesthesia, the patient developed hemodynamically unstable white complex tachycardia, and that was reverted using DC cardioversion. The axis, as we mentioned, was left common femoral axis using surgical cut down, and the right common femoral artery was used for 6 French sheaths for insertion of big tail for control injection, with insertion of temporary pacemaker wire in the right common femoral vein. This is the control angiography using the big tail. As you can appreciate, the well-functioning mitral prosthesis, the aortic valve, and the temporary pacemaker wire in the right ventricle. We accessed the valve using the ambulance left catheter with a straight wire. And after passing the ambulance left wire, we exchanged this ambulance left into big tail guiding catheter, and we inserted the ambulance super stiff wire, and over the ambulance super stiff wire, we passed the valve, as you can appreciate here. Here we are trying to adjust the valve between the mitral prosthesis and the annulus, not to going deep and hindering the function of the mitral prosthesis. We weren't happy about the position of the valve, so we retract the valve and readjust its position. And here is the readjustment. And this was the deployment of the valve in two views. Again, here the valve was released. And we can appreciate that the mitral valve is well functioning, and we did a control angiography from a big tail with no significant paravalvular leak. The axis was fine after closure of the left common femoral axis, and this was the final cine images to be sure that the valve is stable in its position and the mitral valve is also stable. After the procedure, the valve as seen by echo was stable in its position. There was no significant aortic leak, aortic paravalvular leak. As you can appreciate, we have also a severe impairment of LV systolic function. Here is the valve. Here is the aortic prosthesis valve. The gradient across the mitral prosthesis and the aortic prosthesis were acceptable. After the TAVR, we had immediate weaning from mechanical ventilation and intravenous vasopressors. Actually, we introduced the IV fluid with no worsening of heart failure to correct the blood pressure. We gave the patient a large amount of IV fluid, and the patient didn't experience any heart failure more. No evidence of heart block. Temporary pacemaker was removed after several hours. Actually, the patient developed the white complex tachycardia twice after the procedure. However, there was no drop of blood pressure. The patient can stand the tachycardia, and there is no evidence of myocardial ischemia. This was his ECG during the tachycardia and after the DC cardioversion. The patient we see that this patient would need ICD for this tachycardia, but we decided to do it later. This was his discharge medication, warfarin, clopidogrel, sacubitril, valsartan, carvedilol, amiodarone, and we reduced the diuretic dose, as you can appreciate, to torsemide 10 milligram, and the patient was fine on this dose with spironolactone. So this is the conclusion. We should search for the cause of heart failure worsening thoroughly, and aortic valve disease and heart failure carry the worst prognosis among these patients. TAVR offers a practical solution for this high cardiac risk patients, and also it's a multidisciplinary approach, and the key of success is a good preparation. And thank you so much.
Thank you very much. This is a very nice and interesting case with multiple issues. You presented it very well. And I think basically this is a case of severe aortic stenosis hiding behind the initial pseudo diagnosis of problem with the mitral valve. And I think you were quite prudent in searching for the aortic stenosis and diagnosing it, and then managing it accordingly. Did I see the ejection fraction improve afterwards?
Slightly. Unfortunately, this patient was done before the COVID era, so till now we didn't have post TAVR echo. However, the echo that was done after the TAVR, the ejection fraction was slightly improved, and the follow-up, the clinical follow-up with the patient was fine. However, we don't have still a recent study for this patient.
Okay, Hani is asking the questions I wanted to ask, which are both related to the warfarin and the clopidogrel, because apparently the PCI was done like a year before, and I assume it was a non-infarct case. So really, there really probably shouldn't be a reason for the patient to be on clopidogrel with warfarin for such a long time, as it would increase the risk of bleeding. And Hani was also asking about stopping the warfarin during the TAVR procedure.
I thank you, Dr. Hani, for both questions. I already saw them. Regarding the interruption of warfarin before TAVR, actually it was done, and we shifted the patient on low molecular weight heparin till the end of procedure, and the indication of warfarin after the procedure was mainly for the mitral valve prosthesis, mechanical mitral valve prosthesis. Regarding second question, you're completely right. We scheduled this patient this patient on warfarin, and we excuse me.
Can you continue, please? I didn't hear you.
Yes, you are completely right regarding the
indication.
Excuse me, Dr. Hani. I can't hear you. I can't hear you well.
Karim, continue your rationale so we can understand.
Yeah, but the clopidogrel.
I saw your second question, Dr. Hani, is regarding the rationale of clopidogrel on top of warfarin. Actually, yes, this should be stopped. However, the patient didn't have any bleeding episodes, so the initial plan to discharge patient on clopidogrel and warfarin, and to stop the clopidogrel later on and continue on warfarin.
Also, Julia has a question about post amiodarone use.
I was thinking about amiodarone. He had amiodarone 200 QDS, meaning 4 times a day. And I was thinking that...
No, it's once daily. No, sorry, it's once
Is
daily.
it twice a day?
No, it's once daily. It's loaded and then it's once daily. It's
Okay.
started on amiodarone
Because
once
I was
daily.
thinking that was immediately post-TAVR.
Yes.
Okay.
The amiodarone, yes, the patient was on amiodarone before the procedure because he had a recurrent episode of atrial fibrillation during the last year, and we continued amiodarone knowing that it is not the best option, but we decided to continue amiodarone to suppress the atrial fibrillation and the ventricular arrhythmia or wide complex tachycardia that the patient suffered, and planned for an ICD later on. But however, the ICD wasn't done till now.
Definitely. I was thinking, because usually 48 to 72 hours post-TAVR, we can see starting from first degree up to even second degree heart block. That's why I was asking about the amiodarone.
Especially he is on carvedilol also.
Yes, this is a very good point. The patient was on temporary pacemaker after the procedure for, let's say, 24 hours. However, the main indication for amiodarone, because he had a recurrent wide complex tachycardia after the procedure, so we needed to suppress this tachycardia because we're afraid of hemodynamic instability in this low ejection fraction. So we decided to continue amiodarone and close follow-up of the patient.
Dr. Karim, it's a wonderful case, and really you managed to move through the diagnosis and then through the management in an excellent way, particularly implanting a TAVR in a mechanical mitral valve prosthesis. That's quite a challenging situation, but you managed to do it excellent. My concern is about the wide complex tachycardia. And should we think of an ICD for that issue, because it was recurrent and it was very frequent after even the TAVR? What do you think about this issue?
Before you answer, Karim, I'd like to add to Professor Khaled that could it be an ICD or CRTD, because it is a heart failure case. It is a very important question, Professor Khaled, and I think we need to know the opinion of Karim and maybe the other panelists.
Okay, thank you for both. I already mentioned the need for ICD. Regarding the CRT, the patient already had a left bundle branch block. However, it was in atrial fibrillation. It can be done now to place a CRT in patient with atrial fibrillation. Regarding this patient, I would consult really an electrophysiologist. If we upgrade the ICD, definitely he needs ICD. But regarding the need of CRTD, I would consult an electrophysiologist about the indication of CRT, taking in consideration that the patient had atrial fibrillation.
Well, can I ask questions if you have time, Karim, about the aortic regurg?
Yes.
This patient has pre-operative moderate aortic regurg.
Yes.
And we know that post-TAVR aortic regurg has a poor prognosis. So how can we differentiate between residual aortic regurg from the original disease or post-TAVR aortic regurg that is risky and prognostically not very well?
Actually, the aortic valve disease can be a combination of aortic stenosis and aortic regurgitation. And the aim is to solve or correct the aortic valve disease. The most important issue is the degree of aortic regurgitation or paravalvular leakage after TAVR. More than mild aortic regurgitation would be associated with worse prognosis. So every effort should be done to correct aortic stenosis with and eliminating any degree of aortic regurgitation the acceptable aortic regurgitation or bivalvular leak should be less than moderate, should be mild, because more than that would be associated with the worse prognosis.
Also, that implanting the valve. Now, the aim of treating the aortic valve, I think you showed that this is actually, although it seems like it's a mild to moderate aortic stenosis, it's more severe because of the impaired ventricular function. And you would expect that to get the real benefit from the valve, I would expect the ejection fraction to actually improve afterwards. And unfortunately, we do not have the follow-up, because that improvement would impact subsequent decision-making regarding CRTD, for example. Maybe the exocystoles, the ventricular arrhythmias, might need an ICD. But if the ejection fraction improved, then it would just be an AICD rather than CRTD. So,
totally agree, Dr. Ayman. Totally agree, Dr. Ayman. Totally agree.
Excuse me?
Totally agree, Dr. Ayman.
So I think a final step, because to actually determine the benefit of the TAVR regarding his management, it's important to show, if possible, that the patient got a benefit in the form of improvement in ejection fraction, improvement in the heart failure symptoms. And perhaps you might be able to search for this data and perhaps inform us at some point in time.
Sure.
Julia, do you think that the 3D echo will have any role in managing such a case in the decision making? It will make difference to you, the 3D echo here in such a case?
So, recently, thank you, El Said, for this question. I think preoperative planning is very important. You mean, I guess, for the preoperative planning, isn't that? And sometimes what's happening is here, it depends on the experience. Here, for example, they are quite based on CT. And in order to pre-plan the LVOT, not to have a significant obstruction, if they find the CT values that they're inconsistent to prepare the valve, then they will have a TOE intraoperatively and make the decision on the table. So it's always important for us to be standby. And sometimes, we have seen cases that we want the pre-op TOE to help us make the decision.
It's okay.
Okay, I think we probably have to move on. Thank you very much. It's a very exciting case. Thank you, Professor Karim. As always, a very interesting and provocative case, managed well. Thank you very much.
Thank you so much.
Now, it gives me a great deal of pleasure to introduce our next presenter, speaker, Professor Estefania Oliveros from the USA, who will give us her presentation. She's from Temple University in Philadelphia, Pennsylvania, and she will give us her presentation entitled Under Pressure, Hemodynamics, Bringing the Right Fix to Heart Failure. Very exciting and thrilling title. We look forward to your presentation.
Thank you so much for inviting me to speak today. I am very excited to share with you this exciting and kind of like different case. And it shifted somehow how we think about heart failure. And I hope it brings some like great teaching points to the audience. So as an introduction, we have cases of high output cardiac failure that develop in the cases of elevated cardiac index, and this can lead to severe pulmonary hypertension and can be very challenging to manage. There are limited advanced heart failure management strategies for this group, and it's very hard at times to be able to reverse pathology. So I bring today a case of a 65-year-old male with worsening hypoxic respiratory failure. His past medical history was significant for CAD, status multiple PCIs. He at least had 10 procedures done to his coronary artery disease in multiple stages, 2011, 2013, and the latest was in 2018. He had a history of heart failure with ejection fraction of 40% and severe right-sided heart failure. He was a 60-pack year smoker and had paroxysmal atrial fibrillation. An initial part of his relevant history was that 1 year prior, he presented to a hospital where he required impella-assisted percutaneous intervention, PCI, where he had a proximal LED stent that was placed. After that, in the ensuing months, the patient started having a severe bilateral lower extremity edema. It was almost like lymphedema when he presented to us, to the hospital. He had abdominal distension, severe dyspnea. He could barely walk across the room, and he was just gasping for air, orthopnea. The reason why he decided to come in was because he was refractory to therapy in the outpatient setting, despite high dose of diuretics. The medications included apixaban. He only tolerated furosemide 80 milligrams daily. He kind of self-titrated this medication. Metabolism 5 milligrams BOQ daily. He was on aspirin 81, Plavix 75, and carvedilol 3,125, Q12. On his physical exam at arrival, his blood pressure was 97/66, a heart rate of 109. He was afebrile and a respiratory rate of 19 respirations per minute. He was setting 93% on 2 liters of O2, and that was at rest. With mild just movement in the bed, he would desat down to 80%. Jugular venous pressures were elevated up to 20 with very large V waves. This was someone that you actually had to sit up to actually be able to see the top of the jugular venous pressure. He had also an irregular rhythm with a very loud second heart, an audible third sound. Parasternal heave was very prominent in him, and he had a left lower sternal border murmur. He had bilateral crackles and a very prolonged respiratory phase with a chest that was also consistent with someone with findings of emphysema because of the diameter of his AP. His abdomen was distended, and he had very pulsatile liver, which is consistent with the higher jugular venous pressure that you see above mentioned. And one of the interesting findings was that he had a very noticeable audible bruit, was positive with 3 in the right groin. In his ancillary studies, he had a sodium of 123, consistent with severe and chronic hypervolemia and heart failure state. His creatinine was 1.25, which was above like his baseline of like 0.8. Bilirubin of 2.2. He had elevated LFTs, as you can see in the slide, and a mild troponin elevation of 0.09. His initial BNP at admission was 1528, which is abnormal above 100. He had sinus tachycardia, right bundle branch block. EKG had also right atrial enlargement and Q waves in all the anterior leads. His CT was done, and it was negative for acute or chronic PE. And we were able to find an AV malformation, AV fistula in the right femoral vein. This is the initial TT, an EF of 40-45%. And as you can see in these images, and I'm sorry that I'm not sharing the rest of the echocardiogram, he had a very dilated RV, severe TR, bicolor Doppler. He had RVOT notching in the RVOT inflow, suggestive of elevated PVR, and very low flows through the VTI, RVOT VTI. We proceeded also to do cardiac magnetic resonance, and as you can see on the slide to the left, you can appreciate how there's significant amount of desynchrony in the septum, which is consistent with that overcoming RV failure that's in conjunction with the pulmonary hypertension. You can also see on the image on the right a very dilated RV, and you can also appreciate the severe tricuspid regurgitation. When we did late gadolinium enhancement, there was also evidence of scar consistent in the territories where this person had coronary artery disease. I apologize about the images from the left cath. There was patient identification information, so it didn't allow me to show you the whole film. But this is the RCA, which he had that known occlusion that you can see here, almost like a 90%. It was deemed very difficult to access because of how small the vessels were. And that's why in the past he had required like impeller support and the things that I have mentioned. The LAD, you can see here how the proximal stent is still open with some distal perfusion, but it's a very diseased coronary arteries. So in the interim, we were able to obtain some of the images, and we were thinking, why are we having so much worsening of the RV failure? The patient in reality has some component of coronary artery disease, which is there, but it doesn't seem to be able to explain. The coronary angiogram was repeated. The coronary angiogram images that I showed you were from 3 months prior, and it was exactly the same in this acute presentation. So the plan after the patient was diuresed, optimized, but with cardiac indexes that were very low, were to actually think of heart transplantation. He was deemed inappropriate for an LVAD at that point, given the severity of the RV failure. And that's where we started trying to put everything together. Sorry, I apologize. This is, oh no, I gave it away. This is a representation of how like the AV fistula was looking in his right groin. We actually proceeded to do a right heart cath, and where we were able to find an RA initially of 5, RV of 50/16, a PA pressure of 15/24 with a mean of 34, and his wedge was 11. His cardiac index at that point was 2.8 and 5.4. And we were able to find that AV fistula. What we did during the procedure was we actually occluded the fistula, and the cardiac index and cardiac output went to half of what you see on the slide. And there was significant drop in that. And we were able to prove that that AV fistula was actually providing a lot of that extra flow. Then the procedure that was decided, instead of undergoing all these very scary pathway of heart transplantation and whatnot, was to actually close the fistula. And these are the hemodynamics that you see on the right. And this is actually the results of his RV, which is basically normalized. And here is the echo 1 month after. This patient was discharged off milrinone on still some Coreg and aspirin and Plavix. So basically, this is a case of AV fistula that can lead to high cardiac output state and RV enlargement and failure. Concomitant left-sided heart failure and lung disease were thought to be contributed to the severe RV failure and pulmonary hypertension. And given his rapid decline and end-stage cardiomyopathy, he concurrently was undergoing all these advanced heart failure therapies, but simple correction and good physical exam of the AV fistula made a dramatic impact in the improvement of hemodynamics and functional status on this patient. Thank you very much for you.
Thank you. This is a wonderful case, and I think we can summarize it in a very short sentence. Radial PCI. Because if this patient had a radial PCI, he would not have had the femoral complication, and which is probably the reason for it.
Definitely, yeah. So these patients had so many procedures, and I think one of the issues was when they put the Impella for the complex PCI 2 years prior of his presentation, like that's how when the iatrogenic fistula was there. And what's interesting is that he had been seen by multiple cardiologists and transplant centers across for about 2 years, and he was on and off milrinone, and it was just as simple as fixing the fistula.
Yes, please. I thought the symptoms were continuously deteriorating, getting worse after the last PCI. Is that correct, or did I misunderstand?
No, the last PCI that required Impella.
Okay.
2 years prior, yep. Mm-hmm.
Okay.
Can I ask a
Very
question,
interesting.
please?
Mm-hmm.
Can I ask a question? Yeah.
Yes, please.
Dr. Oliveras, this is amazing. Thank you very much. It was very, very educational. Your slides on the right heart cath and the occlusion are beautiful. My question is about the hyponatremia. The sodium was 123, and you said that that was consistent with his state of chronic hypervolemia, right? Did I hear right?
That's correct, yeah.
Yes, because I see this a lot, and I see a lot of panic and people trying to correct the hyponatremia in patients, in fragile patients like this, by sodium chloride infusions and stuff. So if you can just elaborate a little bit more on this. I mean, what was his hematocrit? I mean, was he hemodiluted
So yeah, that's a fantastic question. Thank you so much, Dr. Hagi. This is something that we really see in our heart failure patients when they have severe hyponatremia. And it's also related to this hypervolemic state and dilation of our the atriums, right? And how all it comes down to elevation of ANP, BNP, and the vasopressin in the system, and how you're trying to dilute because your system is thinking that you don't have enough volume. That's what you're perceiving, right? His serum osmolality was very low. He was diluted, even in the pH and like the density in the urine was diluted as well, which was very interesting. And as we just started diuresing and decreasing the pressures in the right atrium and left atrium, you could see an improvement on the patient, and he ended up being discharged with a normal sodium of like 135.
Thank you.
I noticed something else that I found was very interesting. In the pressures, the cardiac pressures, the RA pressure was only 5, which I thought was quite low. I expected it to be much higher than that. Do you have an explanation?
For that, I'm not sure. I think we may have over-diuresed him.
Okay.
To be frank, initially when he presented, he had a JVP of 20. Jugular venous pressure, so we were pretty aggressive on that.
That's excusable, obviously.
Question, please. I would like to ask a question, please.
Yes.
One point, usually with the AV fistula, we have a dilated left side. With this, we usually have a dilated left side. So in this case, I see that he has the dilated right side, which is not the usual with these cases, with this level of shunt. Do you have this explanation for this?
So we think that what happened was that you have a myocardium that's already not very competent because of the prior disease, the RCA. And once the afterload that he already had because of the COPD and emphysema was overcome by an additional volume load that he was just not able to handle, that's when the issue arose.
Okay. Because usually with this kind of thing, we have a left side dilatation. Excuse
Of
me?
course. No, that is correct. Yeah.
Okay, I think we can take one more question, one more quick question. Yes, Professor Tariq, please. Go ahead.
Thank you for this excellent case presentation. My comment about this has to the emphysema, severe pulmonary hypertension. What the role of medical therapy, soluble guanyl cyclase stimulator for the medical management of such a patient? And I want also to comment about the triple antithrombotic therapy. You decided before presentation after PCI to give this patient triple therapy because this patient is high thrombotic risk and low bleeding risk. The rule of Versuguet of heart failure in such patients because the patient has
you cut off a little bit at the end, but I think I caught like the first question and its second question, so I'm going to answer it in two parts. Can you hear me?
Yeah.
Okay, perfect. So the question about the pulmonary hypertension medications, I think it's a fantastic question. In patients that he would have been a combination between group 2, given the severity of his coronary artery disease. This was someone that also had paroxysmal AFib and had tendencies to have elevated left atrial pressures. Consideration for PH therapy in this group, it can be a little bit tricky because you can overload the left atrium pulmonary venules and cause pulmonary vasodilation and worsening of pulmonary congestion, as you know. So it has to be like a PVR to SVR ratio of more than 33% for us to consider that the precapillary component is actually overriding the process. In his case, it didn't meet that criteria. It seemed like the pH was more related to the second component. In patients with disease and emphysema, parenchymal disease, he was on chronic O2, and he had emphysematous changes in the CAT scan. We were just concerned of causing shunting to abnormal lung parenchyma. So that's why we didn't do that. The decision about the triple anticoagulation, like triple therapy, he was on aspirin, and NOAC, I believe, and Plavix. It came because it was decision-making with the patient of risk and benefits.
Okay, thank you very much. I think we have to move on to give Professor Hibatullah Atiyah a opportunity to present her presentation in full. Our next speaker, as I mentioned, is Professor Hibatullah Atiyah, professor of cardiology and specializing in congenital heart disease at Ain Shams University. She'll give us her, she's a real expert in this field, and she will give us her presentation entitled Peripheral Myopathy in Patients with Congenital Heart Disease, How to Manage Them.
Thank you, Dr. Ayman, for this very nice presentation. Thank you for introducing me. I would like to thank IAVA for allowing me to take part in this meeting with among these experts. Hopefully you will like the presentation of my case. The patient, this case was done in collaboration with the Asyut University Cardiology Department, the Division of Congenital and Structural Heart Disease, and especially with Dr. Noha Gamal, Lecturer of Cardiology. She's my assistant there. A female patient, 40 years old. She's a housewife. She had 5 previous deliveries, which the pregnancy and delivery were uneventful, and she has no special habits of medical importance. She presented this time with the dyspnea grade 3 New York Heart Association, and it was gradually progressive through pregnancy to reach this grade during the third trimester. She presented at her 33 weeks of pregnancy. The dyspnea was associated with palpitation. The ECG done showed supraventricular tachyarrhythmias that was diagnosed as atrial tachycardia, which was refractory to medical treatment in the form of beta blockers. Calcium channel blockers were also tried because we cannot use many medications with pregnant ladies. Her echo showed a dilated left ventricle with fair systolic function. Her ejection fraction was 50% by M mode with grade 2/4 mitral regurg. There was a large patent ductus arteriosus measuring 9 millimeters at the pulmonary end with a peak pressure gradient across the shunt of 60 millimeters drop between the pulmonary and the aorta. We discussed the case and we had many options, either to terminate the pregnancy, mind you that she's 33 weeks pregnant, or to close the PDA percutaneously during pregnancy, or to continue with the pregnancy and then close the PDA later after labor to eliminate the effect on the myocardium. Of course, the European guidelines says that delivery before necessary surgery should be considered when the gestational age is more than 26 weeks, and this was the case. So we had to put this in consideration. Our patient has uncontrolled supraventricular tachycardia. She has large PDA, large shunt. She has fair LV systolic function. That makes her grade 2 to 3 modified World Health Organization classification for pregnancy with congenital heart disease. The risk of the PDA, as it shunts large amount of blood because this is a large PDA, and it leads to congestive heart failure. To add to this, the increase in the intravascular volume associated with pregnancy. Pulmonary pressure will rise due to this shunt, and the degree of pulmonary hypertension will pose significant risk during pregnancy and during delivery, increasing the maternal morbidity and mortality. Can we close the PDA during pregnancy? Yes, we can, but there is a very high risk of radiation. Some procedures are done, but if it's a life-saving procedure, and it's usually, if we need this, we have to perform it after 20 weeks of gestation to decrease the effect on the fetal teratogenicity. Extreme caution should be taken as we use a shield to cover the abdomen and pelvis area. After family counseling and consulting with her obstetrician, we admitted the patient to hospital under close monitoring, and we omitted the idea of intervening. We will monitor her just till delivery. 2 weeks later, she spontaneously delivered vaginally at 35 weeks, a baby girl that was kept in the NICU only for 24 hours. She was discharged later on beta blockers, diuretics, and was planned for elective PDA closure. The patients presented 3 months later with the plan to close the defect by the device, but she had marked deterioration in her functional class. She was a class 3 to 4 despite full medical treatment. Echo done revealed global hypokinesia, increased volumes. Her systolic function deteriorated, and ejection fraction was 15 to 20% by M mode. This is the echo after 3 months of delivery. So what happened? Since nothing was added to the condition, we suspected that this was peripartum cardiomyopathy that develops in the last month of pregnancy and or after up to 5 months after delivery. The criteria for peripartum cardiomyopathy is diagnosed when the following 3 criteria are met: heart failure developing in the last month or 5 months later, heart pumping function is reduced with an ejection fraction 45% or less, and there are no other causes for heart failure with reduced ejection fraction can be found in the patient. So she met the criteria of peripartum cardiomyopathy, and no other cause could cause this acute deterioration of the function. What was the next step? We planned to close the PDA so as to eliminate cause that added to her deterioration and deterioration of her general condition. Right heart catheter was done. During the catheter with the right femoral vein access, pulmonary artery pressure was 60/25 with a mean of 36 millimeters mercury. The aortic pressure was 120/50 with a mean of 75, and her resistance was 2.3 Woods unit. This is the injection. Actually, we found that it is a window duct, and the size was larger than that seen by the echo. We usually use a lateral and RAO view, but in this case, we could not visualize her properly with the only the injection. Here we can see the defect is very large, so we decided to introduce a sheath and resize the patent ductus arteriosus in order to unfold the duct and try to measure its proper size. Actually, after seeing this size, I decided to use an ASD device, a large device, because the waist was around 13 millimeters. We did not have a sizing balloon to measure the proper size. I decided to use an Oculotech soft device with 13 millimeters, 13.5 that was available at the time, waist, and it has a left atrial disc that is supposed to be at the aortic size of 28.5 millimeters, and a right atrial disc that will be on the pulmonary end would be 24.5 millimeters. This is the device we used, and this is the left atrial disc with, in this size, it's 28.5, and the right atrial disc, it was 24.5. Here is the deployment of the device. It did not show properly, but in this view, we can see the left atrial disc in the aorta, and the right atrial disc is present in the pulmonary. For better visualization, I used the echo, and in the echo, we can see it's properly seated with no residual shunt between the pulmonary, between the aorta and the pulmonary artery. So after finishing the procedure, the patient, we had to plan for what's the next step. As for lactation, since the lactation has a high metabolic demand for the breastfeeding, so lactation has a class 2B to be stopped in patients with peripheral myopathy with severe heart failure, and promocraptin treatment should be considered to stop lactation and enhancing recovery, as it has an effect on the left ventricle, and this has also class 2B. We initiated immediate medical treatment, stopped lactation by using promocraptin, and started ACE, captopril, added aldactone with beta blockers and diuretics. Promocraptin not only stops the lactation, but it's also used for the treatment of peripartum cardiomyopathy. Since it has a dopamine blocking effect, it affects two pathways. The pathway, and also it has the pathway of the oxidants. It has an antioxidant effect that was supposed to be responsible for the, in some cases of peripheral myopathy, and also it blocks the dopamine receptors that is responsible in part of the theory of the peripheral myopathy. we adopted a strategy that was proposed by German team that was adopted the idea of using bromocriptine in patients with ejection fraction less than 25%. We used 2.5 milligrams twice daily for 14 days, followed by bromocriptine 2.5 milligrams once daily for another 42 days. And we anticoagulated the patient to avoid complications. 3 months later, the patient came with improvement of the overall systolic function, as we see in these different views of the left ventricle, the parasternal long, short, and the apical four-chamber view. After 6 months of device closure and medical treatment with her follow-up, as we see here, this is the presenting echo. This is after 3 months, and this is after 6 months. As we see here, the LV volume has decreased, and the overall systolic function is much improved. And this is the same before, 3 months later, and 6 months in the follow-up. Same here, with marked improvement over the overall systolic function. So as for this patient, the take-home message is, in patients with congenital heart disease in whom pregnancy poses a risk, must be carefully monitored and followed up for safer pregnancy and childbirth. It has been reported that percutaneous intervention can be done, although it poses risk, but still it can be done only in emergency cases. In peripheral myopathy, treatment of correctable lesions that might add a hemodynamic burden should be done as early as possible. Thank you for your very much for your time. Thank you.
Very nice case.
Thank you very much. So very nice case, very interesting and different, and I think it was managed very well.
Can you
sorry, I didn't get the final echo was how long after the
3 and 6 months.
6 months after the intervention.
Yeah.
Yes, yes.
Excellent.
Dr. Ayman, can you hear me? I'm Dr. Raghda Sheikh.
Yes, please.
Good evening, everyone, and Ramadan Kareem. First, I would like to thank Dr. Heba Atiyah, as usual, very nice presentation and very interesting case and a highly illustrative case. Could you allow me, please, to ask here some questions?
Yes, please, go ahead.
Dr. Heba, first I would like to ask you why you don't go and close the PDA during the pregnancy, because you illustrated the death of the patient, and the patient was have a multiple risk factor during the pregnancy that allow you to go and close these PDA. This is first. Second, I would like to ask, what about the supraventricular tachycardia or atrial tachycardia after PDA closure, and why you don't go and do CT before closing this PDA in adults, as we always do CT before going to the cath lab?
We usually do that. Yes, Dr. Raghda, I will answer thank you, Dr. Raghda. It's nice meeting you here, as usual.
For me also, Heba, I like you so much, and I love you so much, and very nice presentation, very nice case.
Thank you very much. First, as for the CT, we usually do CT, but this case was done in Upper Egypt in Asyut, and at that time it was not actually planned. When she came with heart failure, I went and visited them. We didn't have time for the CT. I just got her into the cath lab and the follow-up and intended to close. Even I did not have a sizing balloon at that time. So I went with the procedure without having the sizing balloon because she was in a very bad shape. The patient was not in a good shape. She couldn't lie flat. We had a difficult procedure and we had to work fast. This is number one. Number two, during her pregnancy, her functions was not bad as she came later, because her ejection fraction was around 45-50%. It was not that bad, and she could lie flat. And after discussing with her obstetrician and the family, they opted the idea of intervention. And actually, I was not very enthusiastic, since she could go with her function to safe delivery. And this is what happened. She spontaneously delivered within 2 weeks.
So you basically were saving the intervention when you absolutely had to.
Yes.
You were closely following her to see if she improves on her own, and if needed, then you would intervene.
Yes.
Which is very reasonable, obviously.
Yeah.
Henny,
So
go ahead.
what about the arrhythmia after PDA closure?
Yes, the arrhythmia. Sorry, the third question. After PDA closure, her arrhythmias disappeared. Although after delivery we increased the dose of beta blockers, but when she came with heart failure, we could not add more to the dose because she came with severe heart failure. After closing the PDA, actually the arrhythmias stopped and her atrial tachycardia was controlled. And as you see from the echo, her heart rate was controlled.
Yeah, thank you for the case,
I think
Dr. Heba.
we'll have one final comment from
Dr. Henny.
Yeah,
Henny.
very quickly. I just want to ask you, what did you do about contraception for her? And I want to share in 30 seconds a quick question. You said she had 5 children, and this was the 6th pregnancy. Yeah. 20 years ago, we ran a clinic.
Yes, this was a thing. I asked for tubal ligation. The family refused, but I'm still working on it. I'm still working on tubal ligation.
Okay, 20 years ago at the National Heart Institute, I was part of a tubal ligation clinic where women who have already had at least one child, they should have, these were the rules that were given to us, whom pregnancy would be life-threatening for their existence, where we were offering them tubal ligation without their husband's consent. And the majority were having it done behind their husband's back because the husbands refused. They just wanted baby-making machines.
Yes.
Okay? So we ligated the tubes of hundreds of women. No, we ligated the tubes of hundreds of women. It was just the consent of the patient.
Yeah.
And it was a witness consent. And we were actually stopped by a decree because it was a bunch of us who really believed in what we were doing. This is not something which we've ever published or is public, but I'm telling it to you now. We've tubal ligated hundreds of rheumatic heart disease women who would have died if they had gotten pregnant, all based on their request.
Brilliant
and
idea.
I think patient kind of choice because.
Okay, thank you very much. I think we're just a little bit over our time. I think this was a very exciting session with wonderful presentations, all of them enriching and enlightening. And I think, unfortunately, we'll have to close the session and move on to the next one. Thank you very much for everybody, for the speakers, and for the questions, and a very enlightening discussion. Thank you.
Thank you, Professor Ayman, for this fantastic moderation of this fantastic session and cases with fantastic panelists. And I think we have now to take a break for, I don't know, for a few minutes. Then we will back again to another wonderful, fantastic session with another wonderful professor, Professor Hani Raghi, who will moderate the coming case. Please, we will take a break.
Rafael, hi.
Hi.
It's finally nice to meet you here. We're friends on Twitter, but
exactly virtual thing. Yeah. We hope we could do something for the next year. I hope.
Rafael always gave us a delicious dishes in the Facebook.
Yes, we have today some delicious dishes, of course. We have to get ready for the session.
Okay. We have the last session in our cardio box today. And, I would like to thank Dr. Julia Graspa and Dr. Rafael Vidal Perez and Dr. Giuseppe Vergari for being with us in so late and where they are now. As I just said in the break, in Egypt, we're all awake, but I appreciate that they are staying to be with us. And of course, also Professor Ahmed Shawqi, who will be presenting with us today. We used to think that valvular heart disease was an Egyptian condition because of rheumatic heart disease, and that people in the West did not get a lot of it, at least not in young patients. However, this is changing, and there's a huge interest again in valvular heart disease because of all the percutaneous interventions. And our first presentation today by Professor Rafael Vidal Perez from Spain, Spain, the land of Real Madrid and Barcelona, you like one and you hate the other, probably. We love both in Egypt. Is going to give us an amazing presentation on heart failure due to valvular heart disease. This is a very tricky subject, and we already saw an amazing case earlier, which was treated by Tavi, and now we're really looking forward for this presentation. Dr. Perez and I are friends on Twitter, and he's a fantastic tweet, and I'm so happy to see him albeit on video, but still it's wonderful. Thank you very much.
First of all, I want to thank the kind invitation by you, and also for the JACC case report, Julia Grabsa, the editor-in-chief. And I'm happy to show my cases and to see that the other case was similar but not the same, because I was thinking, okay, they are going to have something similar, but it's not the same. I think, as you say in the one-stop wall, I think the thing is, on valvular disease, I think we have to start to think also in the diseases after changing your native valve. That is things that I'm going to show you in a brief. So this is the first one that I'm going to show you, and we'll try to explain something about the guidelines on some topics. And I will show you some cases from JACC case reports. I think it's also important to show that the things that we find in the clinical practice are the same. So this is a real case, not published in JACC case reports also, but it is a 70-year-old man, hypertension, dyslipidemia. It had at the start the cardiac rheumatic disease that we spoke. He has mitral stenosis and regurgitation. He was treated in 2005 with mechanic prosthesis and tricuspid ring. And in 2009, he has an admission with endocarditis. And the management was medical in that case. He has also atrial fibrillation. And now we have that this patient is in follow-up because other diseases came, like the other case, with severe aortic stenosis and moderate aortic regurgitation. It was in good functional class, and it came to the hospital because of shortness of breath. It was this with 150 of blood pressure, and he was tachycardic, arrhythmic, asystolic murmuring apex, and these signs of heart failure in the X-ray. And we checked in the lab thing that is important in this kind of patients with prosthesis and atrial fibrillation. The NR was low in the last weeks. And this is the first echo. As you can see here, you can see that the left ventricular ejection fraction is more or less near to mild depressed. And we can say here, see here also the aortic stenosis. Of course, it was significant. But if we observe something here, we can start to think that the two leaflets are not working quite well. I think it's very clear here in the four-chamber view. And we have a high gradient here of a maximum of 24 and medium of 7. In other approaches, we can get a medium grading of 10. So we decided to see the valve better. That's the point. And here you can see that it's not always the time the leaflet moving the same path as we see it in the transthoracic. I think it's due to the anticoagulation, but you can see something there that probably could be panels, it could be a thrombus. And the nice thing, and I think it's very useful in this kind of patients, is to check with fluoroscopy what is going on with the leaflets. And you can see one of the leaflets is not moving quite well. I think it's quite important. And this mass, it was like 6.2 millimeters, and we made also a 3D, and you can see here also the valve, but it's not really clear what's going on in 3D for this approach. But the main thing is that we have a mass there. So we treat the patient in the heart failure with diuretics, digoxin, and beta blockers. We corrected the anticoagulation, and we with the unfractionated heparin, and we add aspirin. It could be something to discuss. Of course, as I showed you, we have this partial block with a thrombus, but we don't know if behind it's a pannus or it's a thrombus. That's one of the points. It was not so unstable. We decided not to do fibrinolysis. Then we have this discussion with the heart team that it has very many things to discuss. That's severe aortic stenosis, mitral mechanical valve infarction, so double valve surgery, maybe femoral TAVR, or adjusting well the anticoagulation, or maybe going through a surgical thing of sutureless aortic valve replacement and review the mitral valve. Well, we make studies previously. You see that we don't have coronary arteries disease. We have good femoral access. You can see here that we have not absent of a coronary stenosis, and I don't change the case. You can see that now what happens here, you can see how the leaflets are working well, and it's because we get a better anticoagulation. So probably the thrombus was there. So the decision of the heart team in this case was to go through this femoral TAVR and anticoagulation for this mitral valve, but this happened that the things get solved, but we have a new thrombosis event with new heart failure, and at the end the management was to be surgical in our department, and we went for this sutureless valve, Perceval, and the result was good, and I will show you. This is the 1 month after surgery. You can see that the things are working better. You can see the 2 discs here working quite well. We have less degrees, and of course we don't have the aortic stenosis. So the point here is one of the discussions. I will leave it, I think, for the end, because I will show you now 2 more cases that are similar. Is that the guidelines what say you have to check always if it's an obstructive mechanical prosthetic thrombosis, then you have to go to something more aggressive, like, okay, probably surgery or fibrinolysis. You can wait for this kind of medical management if you have an obstruction, and you have to decide in relation of the risk of the patient. But when the patient is more stable and you see that it's not obstructive at all, you can think on the thrombus side and think what is going on with the anticoagulation. And then you can go slowly, as we made in our case. The point is that also if you have some thromboembolic event or other things, you can think that probably you need to help with the aspirin, but it's not clear if it helps you to a better anticoagulation in this case. And I think another topic that is important is the bioprosthetic valve failure that we could have with TAVR is there, but the risk of thrombosis is lower, as the guidelines say. And another point is more or less the management in the American guidelines is more or less similar what to perform, as we showed you in the case. But the point is here that I think is very interesting, this approach. I don't know if the new guidelines of the European Society will go through this, but I think it's important, this thing of help us to decide when to go to surgery or fibrinolysis, depending on what different things we see in the studies of imaging and how the patient is going on. So I think it's a good thing to remember that this table. Another point is how to decide if it's a pannus or not. It's something tricky. Of course, there are more risk of pannus in mitral valves, and this is another document that I think is very interesting on imaging recommendation of protected heart valves that is made by many societies. And this figure I think is interesting because it shows you more or less some hints to know where is a pannus or a thrombus. And I think it's something that you have to keep in mind. But I want to share with you another 2 cases very fast before I finish these presentations. That is, one is about another mechanical prosthesis, but you can have patients that have an acute coronary syndrome due to thrombus. This was the same case, heart failure. We have a more stable patient in relation with blood pressure, but he needs oxygen, and he has previously a mechanical prosthesis, both aortic and mitral. In the lab test, you find that the patient has some high gradient also in the aortic valve. And when we check with transesophageal echo, this is a case published in JACC if you want to check it more. The mechanical disc were no easy show, but we have the information that it was good anticoagulated when we get the lab test. But when we check it with CT scan, I think it's an essential technique in some cases, and this is well illustrated here. We have this thrombus that is making that this not moving. It's another way to see it with a different technique, but we have good resolution now with CT scans, and we can get this information. And in this case, it has also another complication that it was when deciding what to do with the patient has a coronary event with abnormalities in the LAD, and he needs fibrinolysis to solve his problem. And after all, they made a cath, and you will see here that he has a distal occlusion, and the management finally was with medical management, because it was not, how to say, with all the thing of the thrombus, starting new anticoagulation, they decided that it could be complex to add more things on the treatment. And one of the good things of this case is that they show you how to deal with this situation of what is the valve thrombosis. But the most important thing, I think, is this: when you have this embolism, that this is the strange part of the case, is what to do with you have an embolism due to this thrombus in the valve. That you have to check probably with IBUS and OCT what to do. If a plaque erosion, maybe you need to do a stenting, but this is something resolved with no plaque. Maybe the best solution, like in this case, is to keep anticoagulation. To finalize, I will want to show you another thing that is also TAVR could have thrombosis problems. That is the next step. If your patient has a high risk for thrombosis, that is this situation of polycythemia vera. This patient have another case of dyspnea and fatigue. The same problem, we have some kind of obstruction. In this case, he was with apixaban that it was not stopped previously due to a dental procedure, so we can say, oh, he could forgot to keep the medication, but he was keeping the medication. But in this case, the point was that also we have leukocytosis, and we could think, okay, maybe it's endocarditis. And when they make the transthoracic echo that we'll show you now, you can see these thickened valves that it was due to a thrombosis, and it was confirmed with the transesophageal echo. And at the end, they decided, because it was thrombosis, to change the valve and put a new mechanical one. I think one of the key points is also here that we can go through transesophageal echo instead of CT to check this situation. And I think it's important in this hypercoagulable stage, I did discuss in the take-home message, that you have to be very sure that what is the anticoagulation strategy. I think you were discussing before also what to do if the patient has a PCR or not. I think this is a great document published very, very recently. And I think it's how to manage these patients that have an indication of oral anticoagulation, if they need stents or not, what to do. I think it's something good to review. As also another thing that is this one, because this patient was with apixaban, this one, they decided to keep apixaban for a prosthesis. If you will read these new recommendations just published, they say that, okay, it's acceptable to go with a NOAC in this kind of patients. So to finalize, as Steve Jobs says, one more thing, remember also that when you do another kind of procedures, it's a great paper also to check on JACC case reports. It's also, if you put a mitral clip, you can have many problems also when you solve this. You can have an endocarditis, you can put the clip but not make the things well. Also, you can have thrombus after the transseptal puncture, or maybe leave a different disease like a mitral stenosis. And I think it's another great paper dealing with valve disease. So I invite you to read this paper too. And thanks for your kind attention, and ready to discuss whatever you want.
Thank you very much. This was an absolutely brilliant presentation. I think you tried to show us as well some guidelines, but in reality, all those patients are so outside guideline and trials. These are individual human beings with incredible problems that you managed to, and the treating physicians have managed to help, sometimes using innovative or unorthodox ways. And it's very, very important to remember that all the procedures that we do have complications. We always get shown the good side of cases, but it's extremely important to know that our fragile patients have a lot of them have complications that we don't see. So it's wonderful. Any question from the audience, or would you like to postpone? Are you staying with us to the end, or
Yes,
shall?
no problem. I will there.
Okay. A quick question from Professor Tariq Zawawi, and then we go to Dr. Vergaro's presentation. Then we can take questions for the entire session.
I have a short comment and one question. My comment about the two cases you presented and the case presented by Professor Karim, that the patients with valvular heart disease, we have to interfere early before left ventricular dysfunction. The patients may develop after valve replacement what is called afterload mismatch, and this may cause more deterioration and irreversible left ventricular dysfunction. My question about the patients with heart failure and severe mitral regurg. This severe mitral regurg may be secondary to heart failure, functional mitral regurg, and this functional mitral regurg may cause further deterioration of left ventricular function. For management of such cases, there is a transcatheter mitral valve repair. We have two trials address this point, the MITRA FR trial and the COOPT trial. Actually, the MITRA FR trial failed to show benefit for reduction of mortality and heart failure hospitalization. However, the COOPT trial was positive for reduction of mortality and heart failure hospitalization. What is the explanation for this?
I think, as you say at the beginning, one of the key points is the evolution of the case. I think maybe if you go too late, one of the things that was discussed in between the two trials is how the performance of that ventricles was. Probably in COOPT, they take the patients in a better momentum, I think. This could help to have better results. But in some analysis, some people say that this was not related with volumes or remodeling of the left ventricle. But I think probably in some of the cases, if you wait too much, you don't get the benefit. So I think, as you see also in my first case, the aortic stenosis probably was giving more problems. He was to be intervened because of the problem of the mitral, but he has depressed left ventricular ejection fraction as least mild, and probably it's also too late for aortic stenosis. So in valvular disease, I think waiting it's not the best decision.
Thank you.
Thank you. Any more questions now? Or anyway, if any of the audience has more questions, please keep them to the end because we've still got two more presentations. And Dr. Perez is going to be staying with us. We're grateful for that. The next presentation has an intriguing title. It's by Professor Giuseppe Vergaro from Italy, who's written a very nice paper that I remember reading on mortality in different groups of heart failure patients in 2019. But this presentation today is about a subject that I'm very interested in, which is cardiac amyloidosis, that I've been working on very hard for the last 3 years. And it is intriguing because it's sequential transthyretin, TTR, and immunoglobulin light chain cardiac amyloidosis in the same patients. And that is something which sounds amazing. And I'm really looking forward to hear this presentation. Dr. Vergaro, please go ahead. And thank you for being with us.
Well, good evening or good afternoon, everybody. It's a real pleasure and real honor to be with you this evening. Yes, indeed, we are shifting the topic of the presentation from valvular heart disease to cardiomyopathies, let's say. And yes, cardiac amyloidosis is a field of growing interest basically everywhere in modern cardiology. And we have also approached cardiac amyloidosis since, let's say, 6 or 7 years, and we have studied this disease a lot. And this is a very nice case, in my opinion, really explicative, and we have published it in Jacques' report as well, together with my team in PISA. Just trying to go on with my presentation. Sorry. Okay, so and these men first came to our attention in 2016. It was 80 at the time, and he had a history of hypertension, and he also had, like a lot of patients at that age, he had been diagnosed with a monoclonal gammopathy of uncertain significance, which was typed as EGMK. And he first came complaining dyspnea, which was at that time near class 2. His blood pressure was 130/80 and heart rate was 76 beats per minute, and physical examination was basically unremarkable. You can see his EKG showing some mild abnormalities in ventricular repolarization in lateral leads. And these are frames from his echo, who was showing an increase in septal and posterior wall thickness with a preserved left ventricular ejection fraction and a grade 1 diastolic dysfunction. This is the movie of the echo, and also the mitral regurgitation, which was mild, basically, is shown. Going on to the lab biohumoral examination, well, a moderate increase in NT-proBNP was observed, it was 460 at the time, and also high-sensitive troponin T was mildly elevated, which was as up as 24 nanograms per liter, in the presence of a preserved renal function, as shown by the creatinine levels, which were basically normal, was less than 1. Coherently with his previous diagnosis, a monoclonal EGMK protein was detected at that time with a basically preserved K to lambda ratio. And also the urinary immunofixation showed a kappa-Bence-Jones proteinuria. We went ahead in terms of phenotypic characterization of this patient by performing cardiac magnetic resonance in order to identify which was the cause of this left ventricular hypertrophy. And also the cardiac magnetic resonance confirmed the presence of an increased left ventricular mass index with maximal septal width of 23 millimeters. Also, a mid-wall late gadolinium enhancement was detected at the anterior septum, as well as subendocardial LG at the inferolateral and the inferior left ventricular wall. So, in the suspicion, indeed, of the presence of transthyretin amyloidosis, the patient was submitted to, of course, a diphosphonate scintigraphy, showing a very mild uptake in the cardiac region. I've also shown the 3D reconstruction of this examination, because indeed it was pretty mild. It was classified as a Perugini score 1, and it was mainly localized at the septal and the inferior wall, as shown in the panel on your right. So we decided to go on and to further explore a possible diagnosis of this patient to confirm our suspicion of transthyretin amyloidosis by performing endomyocardial biopsy. Of course, we first performed coronary angiography, who could not show any hemodynamically significant lesion, and also the periumbilical fat biopsy, which was negative, as frequently happens in TTR amyloidosis. On the other hand, endomyocardial biopsy showed was positive at conglomerate conglomerate staining, and the immunohistochemistry demonstrated a positive staining for transthyretin, while kappa and lambda staining was negative. The patient was further studied on genetic background, which could not show any mutation in the TTR gene. So our diagnostic conclusions was were basically the ones confirming an early stage ATTR wild-type cardiomyopathy. And the patient was initiated with therapy basically for heart failure with bisoprolol, valsartan, and spironolactone. As you can see here, this is a picture taken from the latest recommendation published only a few weeks ago concerning the diagnosis and management of patients with cardiac amyloidosis. Our choice was indeed coherent with the current indication. Indeed, our patient had grade 1 scintigraphy, but most importantly, he had positive hematological test. What we can learn from these kind of approaches that whenever we have any suspicion of cardiac amyloidosis, these are those tests that needs to be performed. So on one side, dephosphonate or bone tracer scintigraphy. On the other side, the study of the hematological tests. And since we had mildly positive scintigraphy and also positive hematological tests, the patient needed, as it has done, an histological confirmation and the typization of the amyloid. The patient was then followed up at our clinic during the following years, and he maintained clinically stable. In the meanwhile, he also was performing his routine evaluation at the hematology department, where he was diagnosed in 2018 with Waldenstrom macroglobulinemia. And he also repeated an HDP scintigraphy in April 2018, showing an increase in cardiac uptake, which was now scoring 2 at the Perugini score. Things changed more or less 3 years after his first admission at our department in January 2019, when the patient started complaining worsening dyspnea, which was at that time in NIA class 3, and also presented at our attention with mild bilateral ankle edema. At that time, cardiac biomarkers had increased, and NT-proBNP reached more than 2,500 nanograms per milliliter, and also eye-sensitive troponin T had increased up to 48 nanograms per liter. The K to lambda ratio also increased to 4.2. As you remember, it was preserved at the first evaluation. The patient was therefore referred for baseline echocardiography, showing an impairment in left ventricular ejection fraction, with also mild pericardial and bilateral pleural effusion. These are the images from his echocardiography. You can see also that the entity of the severity of mitral regurgitation had worsened at time of our second assessment. And this is a panel showing how all the diagnostic examination have changed during these 3.5 years follow-up. As you can see, most notably, the diastolic function has worsened since 2016 to 2019, and also the extent of left ventricular hypertrophy and the extension of late cannulinium enhancement at cardiac magnetic resonance examination have significantly worsened during these 3 years, as did also the HMTP scintigraphy, shown by the panels on the right. What is of interest indeed is that in this case, the patient has been diagnosed with Waldenstrom macroglobulinemia, which is not indeed one of the most frequent plasma cell dyscrasia that we currently see in patients, especially in older patients, like, for example, the MGUS smoldering myeloma or also the multiple myeloma. But these came to our attention, and we decided to go on with other examinations in this patient. Of course, the coronary angiography was performed again and did not show any significant difference compared to the previous angiography performed in 2016. And we decided to further explore this case by performing again, a second time, a myocardial biopsy. And we were not surprised indeed, given the clinical presentation of the patient, to discover that further to the transthyretin amyloidosis that the patient was already documented in this patient in 2016, and which had indeed extended as demonstrated here by the immunohistochemistry, which was already positive for TTR in 2016, but was much more positive now in 2019. We also observed positivity for kappa light chain. So we concluded that the patient that suffered at that time of dual cardiac amyloidosis, of both type, ATTR wild type and AL. The patient was thus initiated with hematological therapy with oral chlorambucil and prednisone. He had no treatment-related complication, and was referred for a routine follow-up at our outpatient clinic. Last contact was on November 19, and was asymptomatic with no sign of congestion. Left ventricular ejection fraction had improved to 56%, and he has also shown a partial hematological response to chemotherapy, as demonstrated by a decrease in kappa 2 lambda ratio. So what are the main messages I want to conceive to you with this presentation? Well, the first of all is that cardiac amyloidosis is not that infrequent, and it may account for a significant number of cases of heart failure, especially in the elderly population. Another important point is that we need to perform a timely diagnosis of cardiac amyloidosis, especially for those patients in whom AL amyloidosis is suspected, because the early initiation of hematological treatment can save life. Another important point is that on one side, ATTR amyloidosis can coexist with other disease. It is a disease of the elderly people. So if you have a patient with, for example, another cardiomyopathy or with coronary disease, well, ATTR can coexist with all these diseases. But also ATTR and AL amyloidosis can be present in the same patients and can develop in different time during the lifetime of a single individual. So there are different, indeed, red flags that we need to consider when to raise the suspicion of cardiac amyloidosis in different patients, and all these red flags can come from different fields, from the clinical presentation, from the EKG, from the imaging, and also from biomarkers. These need to be particularly taken into account, because they can provide us with a very early signs of clinical worsening and of eventually the appearance of another alternative type of amyloidosis. And this is indeed reflected by what we have stated in a recent paper published in the European Journal of Heart Failure, demonstrating that also mild elevation of cardiac biomarkers can be indicative of early stages cardiac amyloidosis. And those elevated levels of high sensitivity troponin or anti-proBNP or the BNP, which we are used to observe in patients with amyloidosis, usually reflects a disease which has been diagnosed pretty late in its clinical course. So thank you for your attention.
Oh, thank you very much. This was an amazing case. I mean, and we've seen the comments coming from all the panel. I must have missed something. Can I just ask you a question, which is probably a very stupid question, so don't be angry.
For sure.
Yeah. If I just say, why is this not just AL amyloidosis? Why is it combined TTR? I mean, the SPECT is negative. Congo red will still stain any amyloid, even subcutaneous fat in an AL amyloidosis or a biopsy from the colon will stain with Congo red. I mean, Congo red is not specific for ATTR, right? It's for all amyloidosis. So why is this not just simple AL amyloidosis because of the macroglobulinemia? Why are you saying that this is also TTR? I'm sorry, I'm a beginner in amyloidosis, and I hope you're not upset by this question. But, I would have just diagnosed AL amyloidosis and sent him to a hematologist. I don't see the proof of the TTR.
Well, indeed, we have two different proofs of the presence of ATTR amyloidosis. One, which is indirect, coming from bone tracer scintigraphy, which was only mildly positive at the very beginning and then worsened during the follow-up. And the second proof is that the amyloid tissue within the heart was underwent a typization with immunostaining. And that immunostaining revealed the presence of TTR within the amyloid, together with light chains. So that's why we have diagnosed a combined amyloidosis.
Okay, thank you.
Hope it was enough.
Yes, just another quick follow-up question.
Yeah.
This is a case report. You mentioned at the bottom of one of the last slides that they can exist in the same patient. Are you aware how many cases were reported with both types of amyloidosis in the same patient?
Well, in our center, we have 7 patients with both AL and ATTR amyloidosis, but this was very special as a case because we had the chance to see the development of the disease at 2 different time points. So this patient did not suffer of AL amyloidosis at first examination, while he had the time to develop another disease during his follow-up. But if you see the patient at an exact time point, well, you can see both AL and TTR amyloidosis, especially in elderly patients.
Okay, can I ask?
Okay. Yes, I think Dr. Graspa would like to comment as well first. Can we ask you to?
It's a wonderful case. I mean, fascinating. I was mind-blowing, beyond my understanding, to be honest. So this I would like to comment. I don't have any special comments. Only I would like to say my apologies because I won't be able to see the last case because we have a meeting with Dr. Fuster in 10 minutes. So to all of you that you are watching, my sincere apologies that I will leave slightly earlier.
Thank you, Julia, for joining us. And I know that you have a meeting now with Professor Fuster. Thank you again. Before we will conclude the session after Professor Shawi, thank you again for your support by JACC Case Reports. And I think we still, despite we are in the 5th wave, but we still have a long way for MERGE meeting together. And I think we will talk later about our future plans for the coming waves. Thank you, Julia, and have a nice meeting with Professor.
Thank you so much. Thank you all. And as I texted you that few cases, they're so amazing that please submit also to the journal. So thank you so much, all of you.
Thank you, Julia. Thank you very much.
Professor Hani, continue.
Yes. I think there was a question. I interrupted the question, did I?
Professor Tariq.
Yeah.
I have 2 questions. Thank you for this excellent case presentation. For diagnostic algorithm for patients with amyloidosis, do we need to do for all patients technetium scintigraphy and light chain? The first one. The second question about the anticoagulation, the role of anticoagulation. Cardiac amyloidosis patients are at risk for intracardiac thrombosis. Is the role of oral anticoagulant in patients with sinus rhythm?
So thank you very much for your question. Well, concerning the therapeutic option, we do have therapies which are hematological therapies for AL amyloidosis. The availability of drugs addressing TTR amyloidosis are heterogeneous across all over the world, depending on the status of the local regulations and the approval of the use of some of the drugs which are coming to the use in this context. Well, yes, whenever you have the suspicion of cardiac amyloidosis, there are two tests which are mandatory. The first one is bone tracer scintigraphy. The other one is the study of the hematological pattern. As concerns the last question, what is the rule of anticoagulation? So I will start with what is the rule. So the rule is to use the same criteria in patients with cardiac amyloidosis as in all other patients. So this is the rule, because we don't have any other recommendation, or there is no robust evidence supporting any other behavior. But what I think, but this is a personal opinion, is that we should keep the threshold for anticoagulation lower in patients with cardiac amyloidosis, because they have, we have described several cases of patients with peripheral embolism and also with stroke in patients with sinus rhythm and cardiac amyloidosis, because you have, especially in patients with AL amyloidosis who also have abnormalities in coagulation, you have an atrial standstill, which has been documented by advanced echocardiography and also by cardiac magnetic resonance, which may lead to the development of intracardiac thrombi in these patients. So what we think is that as soon as you have something, I mean, and the minimal reason to use anticoagulation, you should use in these patients.
Yes, thank you very much. That was a great question, Professor Tarek, and I agree. This atrial myopathy with lack of atrial contraction, is something which has been noticed in cases of amyloidosis. I have one last question. You mentioned at the beginning of the workup that you started the patient on several treatments, including valsartan. Right? Am I right?
Yeah.
And those patients don't do very well on conventional heart failure treatment. Actually, some of them get worse, as you know well. So how did the patient respond, and what was your rationale for giving standard heart failure treatment to this patient?
So there is indeed a lot of concern about the use of neurohormonal antagonists in patients with cardiac amyloidosis. What we do is to use them cautiously, because there are at least a couple of reasons. The first one is that we have demonstrated the presence of neurohormonal activation in patients with cardiac amyloidosis who have elevation of aldosterone, renin activity, and also epinephrine and norepinephrine. So that is the rationale. The second point is that these patients may benefit, for example, from beta blockers in terms of reduction of heart rate, which is, this is, in my opinion, less than compensatory. The point is that these patients usually do not or scarcely tolerate neurohormonal antagonists if these drugs are used as in all other patients. So you should be even more cautious when initiating and titrating this drug. The titration should be much, much slower than in other patients. And using this kind of tricks, you may introduce and keep these patients with this treatment that potentially may be useful in these patients.
Thank you very much. That was really wonderful. Any more questions from the audience or the faculty? I'm looking at the chat. There's no more questions. So thank you very much again. And now I welcome our last but not least speaker, a personal colleague and friend, Professor Ahmed Shawqi, Professor of Cardiology in Ain Shams University, who will tell us heart failure is not as easy as it seems. I think none of us thinks it's easy, but it's still a very attractive title. Professor Ahmed Shawqi Salafi.
Professor Hani, everybody, it's been a lovely meeting. I have enjoyed everything so far. It's excellent. Dr. Said, as usual, Very nice. Thank you, Dr. Said. Actually, it's a good thing that I chose this title because I really changed the case very late because I had another case coming up for follow-up, which was really interesting. And this case is a 56-year-old gentleman. He's an ex-smoker with recurrent history of asthmatic attacks and sinusitis. He's been hypertensive for the past 8 years. He's taking many different medications, but beta blockers usually had an aggravation of his asthma attacks. And of course, he was a smoker, but he stopped. So he presented to a hospital with an acute shortness of breath, and his troponin was positive in this hospital. There was ST segment depression in the lateral leads with an impaired ejection fraction, as you can see, and segmental wall motion abnormality. Okay, so it seems like an acute coronary syndrome. What to do? Rush to the cath lab. And he was, an angiogram was done, and as you can see, nothing of significance. I'm not going to go into details of the angiogram, mild atherosclerosis. So diagnosed as a case of myocardial infarction with non-obstructive coronary artery disease. So he was given dual antiplatelets, high-dose statins, small dose of valsartan, post-myocardial infarction, and ivabradine because of the beta blocker intolerance that he has because of his asthma attacks. So, okay, seems like a case that we see every single day, and we're just going to follow up. But this is the presentation that I saw, which was 4 months after the first presentation. He came with chest pain, acute chest pain. He went to the ER. There was some shortness of breath, and with that, on examination, he was orthopnic. There was bilateral lower edema. There was a little bit of basal rales. Actually, the blood pressure was 140/90, heart rate was 90. There was a little bit of rash on his arms, and he had an apical third heart sound. Chest pain, shortness of breath, but mainly chest pain, actually. His ECG, again, you don't see something of major significance. There was no ST segment changes that signify a big insult. But we went into the labs. His creatinine was okay. His ESR was elevated. CRP was also elevated. His CBC showed lymphopenia and eosinophilia. So we're talking, is this positively a COVID myocarditis or something like that? But actually the PCR for the COVID-19 was repeated twice, was negative. His troponin was markedly elevated. You can see the numbers, maybe 30 times the normal. His end-terminal proBNP was also increased, and his chest X-ray and followed up by a CT showed bilateral pulmonary infiltrates, and the report said not typical of COVID-19 actually this pulmonary infiltrates. So what are we doing here? Is this another acute coronary syndrome? So he was admitted to the ICU, simple as to go. He has chest pain, he has shortness of breath, he's a little bit congested, IV diuretics, IV nitrates, simple as that. But what about antiplatelets? Do we do it? He's already on aspirin and clopidogrel because, again, ticagrelor really aggravated his asthma attacks. Do we do another coronary angiography? Is this a repeated case of Minoka? So actually, when I passed upon this patient and looked up and asked for the further investigations, I said, no, we're just going to control the symptoms. This might be some sort of inflammation. This might be some sort of COVID-19. But actually, later on, I said, this is not a COVID-19 myocarditis. He's been negative. So the echo this time, instead of 42, it showed a drop in the ejection fraction to 30 with increase in dimensions, mainly the end systolic. And non-diastolic, the diastolic function was actually grade 2 diastolic dysfunction with global hypokinesia. So what's the next step? Actually, I wasn't rushing into an angiogram. I said we will stabilize the patient, and then we're going to send him for an MR. And we did the cardiac MR. And what did it show? It showed mild myocardial patchy scars, basically, mostly involving the interventricular septum. And these are cuts. I just want to cut it short. But what's important, it's suggestive of chronic inactive myocarditis. So this is myocarditis. And this is MR done maybe 2 to 3 weeks after discharge because the patient, had a little bit of problem getting to do the cardiac MR. We stabilized them, and this shows that this is a myocarditis. This is not an infarction. The patient has myocarditis. But what to treat, what to give? He has pulmonary infiltrates, what to do? What's the diagnosis? And this is the important thing, because if you don't know what the patient has, you don't know what the treatment plan will be. okay, we're giving supportive therapy for his heart failure, we're giving supportive therapy for his congestion, but this is not the final. So what's the cause of all death? So we asked an immunologist, and they helped us, and we follow them up, myself and the immunologist, quite frequently. They asked for a wide array of investigations. Anti-nuclear antibodies negative, ANCA was negative, C-reactive protein was elevated just on admission. There was an increase in LDH, no anti-streptolysin OTH, infectious screen for any type of myocarditis was not significant. There was an increase in IgE. Of course, don't ask me what does this mean, because I'm a cardiologist. I don't know what this means. But after that, they put him on a score chart done by the American College of Rheumatology after they evaluated the patient, and they looked at the history of asthma, the eosinophilia, which was an important marker for diagnosis, the pulmonary infiltrates, which is not uncommon in these diseases, and the paranasal sinus abnormalities, which was seen on many CTs. And this actually goes up to a high predictive value for diagnosis of what we used to call the Churg-Strauss syndrome, or the eosinophilic granulomatosis with polyangiitis, which is the new name of Churg-Strauss. So a little bit of history. This was seen in the early 50s, and it was characterized by asthma, eosinophilia, and granuloma formation, and some vasculitis. This has many differential diagnoses. It has a prodroma phase when there is asthma, allergic rhinitis, and eosinophilic phase when there is eosinophilic infiltration and increasing the eosinophilic count, and there is a vasculitic phase. But our patient had myocarditis. There was nothing in the vascular tree. The pathogenesis actually affects mainly the medium-sized muscular arteries, but there are data that it can infiltrate the tissues with eosinophilia, and this can happen. Its manifestations are multiple. There are systemic manifestations of fever, weight loss, maybe joint pains. It can cause pulmonary involvement with patches as seen in our patient. We can see nervous system involvement in some cases like neuropathy, which is very common in certain patients. A rash, which the patient did come with, and they told us retrogradely it could be the rash of Churg-Strauss. This is not the picture of our patient. Gastrointestinal involvement, including eosinophilic gastroenteritis, pancreatitis, or even cholecystitis and peritonitis. It can cause renal involvement, which usually has a focal segmental glomerulonephritis. But the leading cause of death, and this is something I did not know, is cardiomyopathy and myocarditis, especially eosinophilic myocarditis. So this patient had this. And actually myocarditis, which is the most common eosinophilic myocarditis we know is the Loeffler syndrome, which mainly is restrictive cardiomyopathy. But no, in Churg-Strauss or EGPA, it does occur. There are 3 stages. The first stage is in which there is infiltration of the eosinophils into the myocardium. Then there is hypercoagulability and formation of thrombi. But here, could this thrombi have induced the acute coronary syndrome that was seen in the first presentation? And then there is fibrosis, and then there is permanent cardiac dysfunction. And actually, if you do a cardiac biopsy, you will find this eosinophilic infiltration. We sent the patient, and we told the patient for a myocardial biopsy was going to do it at Magdi Yaoub Center in Aswan, but the patient refused multiple times, actually. But the rheumatologist and the immunologist said this is probably a case of that and that. So how do we diagnose this disease? There are 4 out of 6 criteria, the criteria that we use to diagnose our patient. This is the American College of Rheumatology classification, but there are 2 other ones, the Lanham's criteria, in which it has to include asthma, eosinophilia, and systemic vasculitis in 2 or more extrapulmonary sites. The Chapel Hill consensus, which is asthma, eosinophilia, and inflammation informing the respiratory tract or vasculitis in the small to medium vessels. And we should take into consideration there are so many different laboratory investigations that we might not find. And actually, an ANCA negative Churg-Strauss syndrome has a very high predictive value that it can cause myocarditis. Actually, most cases of myocarditis occur in the ANCA negative, not the ANCA positive Churg-Strauss syndrome. And I know you're thinking this could be another disease. Yes, in the allergic phase, it mimics sarcoidosis. In the eosinophilic phase, it can mimic rheumatoid arthritis or hypersensitivity pneumonitis. And in the vasculitic phase, of course, the biggest differential diagnosis is polyarthritis nodosa and Wagner's granulomatosis, but the myocarditis in these two diseases is quite rare than the Churg-Strauss syndrome. How do we treat? And this is why we're trying to find a diagnosis. The patient was put on medications, but this is just a review on what treatments can be given. Glucocorticoids, there can be cyclophosphamide, intravenous steroids in certain cases, even up to intravenous immunoglobulins and our monoclonal antibodies. Our patients are also having a good or poor prognosis. This is according to the French Vasculitis Study Group scoring system. If we have a one factor of the 5 above, which is elevation of the serum creatinine, proteinuria, GIT involvement, cardiomyopathy, or CNS involvement, then you have a 5-year mortality. Look at the number, 25. It's not something to be taken very lightly. If you have more than 2 factors, it can go up to 46 or even higher. So our patient who started on corticosteroids and cyclophosphamide, of course, the doses definitely were not according to my recommendation. It was according to the rheumatologist. And actually, this is why I tried to change the case, because he just came last week to me. After 5 months, he's ambulant, his ejection fraction is improved. He's still on sacubitril valsartan, ivabradine to control the heart rate because beta blockers really aggravate the asthma, eplerenone. And this is a really lovely case to see why the change in the definition of heart failure, that this patient, you might think myocarditis will resolve in nearly all patients. This patient has an impaired ejection fraction. This patient has not a recovered ejection fraction, has an improved ejection fraction, and this is the new definition as published just a month ago. So hope I didn't take a long time. I know it's late at night, but heart failure is a common complication from different entities. And this eosinophilic granulomatosis, the Churg-Strauss, that's the older name, is a very rare condition. I haven't seen it maybe twice. This is the second time I've seen it. And it can cause multiple system affections. The cardiac involvement, which is quite rare, is the #1 cause of death in these patients, actually. And the correct diagnosis, you might think, okay, so what? If it's Wagner's granulomatosis, we'll give steroids. No. Actually, the management might differ from different diseases and the doses might differ from different diseases. But actually, we were able to reach the diagnosis, and this patient may be doing well because we are treating him correctly. And thank you.
Thank you very much, Professor Ahmed. Like the 2 previous presentations, this is a very special presentation because it shows that medicine is not mass production. Patients are human beings, and for the patient with a rare condition, like this case you just showed us, or the amyloidosis case we saw a little bit earlier, it's so important that somebody remains on the hunt, remains vigilant, and diagnose their case. Even if, as you said now, you will see in your entire professional career only a few of such cases, but it is extremely important to keep on going after the diagnosis, despite the frustrations, despite the fact of whether even a condition has a treatment or does not. And this is very important. I just want to ask you one question. In Egypt, we don't have a lot of myocardial biopsy. Do you think this is something that we should do something about? I mean, instead of like having to send them to Aswan. I mean, I see no reason. I see no reason why a place like Ain Shams University or the Heart Institute or Cairo University would not have a myocardial biopsy. It's actually not a very technically challenging procedure.
Actually, we did have it, and and also I think in the National Heart Institute you had it, but again there was a lot of demands. There was a lot of changes in the guidelines, and actually there's not a really big interest. But I think when you have something, actually it's very simple. I've seen maybe 5 or 10 cases, but it's not done a lot right now, which is a bad thing. Sometimes they help. It's not very commonly used, and there are guidelines when to use them and when not to. But yeah, it's not a demanding or a technically problematic thing. But actually, our patient did not require the myocardial biopsy to be 100% diagnosed. But I agree, it would have, finished the whole diagnosis and made it clear as water.
Yeah, I just find it very strange that Egypt, with a 100 million population and maybe 10 or 15 cardiology departments in universities and big government hospitals, does not have even one center where we can all refer our cases. So maybe we can take an advantage of this small meeting to focus on this point. Maybe we can do something about it. Thank you very much.
Thank you.
Is there any questions from the audience?
Yes, please. Professor Hani?
Hi.
Hi,
Oh, you're
Professor.
looking wonderful.
Thank you, dear. Professor Ahmed, it's amazing. I really enjoyed. It's quite a rare case, and I would like to ask you, what grabbed your attention primarily that this could be the diagnosis of that case?
First of all, I just hate everybody with chest pain and a little bit of troponin to just go to the angiogram repeatedly. And he just had an angiogram 4 months ago, which was actually nothing of significance. We're in the era of COVID, and in COVID, actually, we see a lot of myocarditis. And this was my first diagnosis. This is myocarditis due to COVID. This patient might need, antiviral and corticosteroids and stuff like that. And we work as a unit, actually, with the pulmonologist, with the immunologist, with the nephrologist. I'm not going to talk about the doses of the things I don't know. We get whoever can be there. PCR was negative. Okay, so there's something else. We repeated the PCR again, negative. So we were looking at other things. And actually, the person who really put this into consideration, I'll tell you, the MRI does not diagnose Churg-Strauss or eosinophilia, but it was the rheumatologist, and just following up our patient between me and the immunologist really helped us go there. But I did not have, I said the myocarditis, and what it is, I don't know, to be honest.
Yeah, thank you very much. Just one quick question, quick comment. Professor El-Sayed, I'm so thankful for this wonderful meeting, and I just want to say that, do we need, as cardiologists, to implement the SGLT2 inhibitors as part of our armamentarium in the treatment? I've seen a lot of cases tonight, and all of them are wonderful cases. And I think that I have not seen in either of them the SGLT2 inhibitor as one of the cornerstone medications that we should implement in our treatment. Should we revise our strategies and thinking, even in non-diabetics, etc., etc.?
Dr. Khalid, I'd like to answer this question, because as you see from those fantastic cases tonight, the turning point here was a procedure which changed the management, changed the heart failure status, changed the aggressiveness of the heart failure progressiveness. So that's why tonight the procedure done in a lot of cases turned out the management phase of the management of the case. So that's why it might be, yes, I totally agree with you that it might be one of the medication options, but here we give the message that you have to think sometimes that the procedure may change the phase of the management of the case. According to the case of Professor Shawi, I think that the story is totally different here, because the steroids, which is contraindicated in the treatment of the heart failure, here is the treatment of this case. So I think those are the messages came up from the cases, which was really, I totally agree with you. Despite we are in the case box, but all the cases are out of the box, actually. All of the cases are out of the box. Thank you all. Professor Hani, if you allow me, if there is no any further questions, and as you said, yes, Professor Tariq, please.
I would like to thank Professor Ahmed Shawqi for this excellent case presentation. I think that the feedback from this case, we have to search for the diagnosis of heart failure. And the key points in such patient, the presence of eosinophilia and the white cell count was high. The leukocytic count was 14,000. This is not in favor of viral infection. Leukocytic count was high due to the presence of eosinophilia, and the patient has skin rash together with lung infiltrates and the history of asthma and normal coronaries. We have to search for another cause for this is the learning feedback from this case. We have to search for, and the cardiac MRI in such situations is very helpful for diagnosis, whether the amyloid cardiomyopathy or the eosinophilic cardiomyopathy. Very important. We have to search or to use the cardiac MRI for such diagnostic purposes. I thank you for such.
I see here, Dr. Tariq, as you said, a comment from Dr. Karim that it is important always to lock a simple measure as a differential CBC. Differential CBC may be a clue for diagnosing the Professor Shawqi case. Professor Hani, if you allow me, please, to conclude this fantastic night with wonderful out-of-a-box cases in the CaseBox fifth wave. I'd like to thank you all, Professor Ashraf Reda, Professor Atif Al-Bahari, Professor Ayman Abu Al-Majd, Professor Hani Raghi for their wonderful moderation of the cases, and also the case presenters, Professor Karim, Professor Heba, Professor Shawqi, Professor Gispo, Professor Rafael, and Professor Stefania Oliveros, Professor Raghda Sheikh, Professor Tariq Al-Zawawi. I'd like to thank you all for your wonderful presence tonight, and I promise that we will keep going the CaseBox waves with JAK case reports with another wonderful cases. Thank you all and have a wonderful night. Bye-bye.
Bye.
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 Thank you.
Bye-bye.
Bye. Thank you.
Thank you, Dr. Khaled. Thank you, Professor Khaled. Thank you very much.
Bye.
Bye.